My job here is to tell you about the crown data in Lorlatinib and briefly review the Lorlatinib as a drug, which we have been successfully using in the recent times. So, Garima, if you can share my screens. Can you play this? Yeah. So, can you go next slide? So I'm going to present today data of Crown trial data, which suggested that Lorlatinib as a first-line option in metastatic ALK positive mNSCLC, and which has sort of changed the paradigm of this disease completely. If you look at the disease background in lung cancer, it is probably the second most cancer causing death, commonly diagnosed and causing death in 2020. And I feel the incidence of lung cancer is tremendously going up. NSCLC accounts for 80 to 85% of cancers. I see small cell cancer rarely now in my practice, and I think my colleagues will echo the same. It is probably because, I don't know, because of more filters coming up, the incidence of small cell cancer has gone down. Even in smokers, we are not seeing much of small cell cancers. The 5-year survival rate is still dismal, in patients with non-small cell lung cancer, and it's only 7% in patients with distant metastasis. So if you look at this pie chart, which has been taken from Piker et al. In lung cancer, you can see that lung cancer today has evolved from NSCLC, SCLC to adenosquamous large cell and other lung cancer subtypes. Can you go to the next slide? Garima, next slide. I think, Garima, can you hear me? Next slide. Or let me share my screen. Which says that how the lung cancer, is varied between male versus female, how the demographic change has been. That now we are seeing more and more females with diagnosed with lung cancer, and by 2040, WHO predicts that the difference in the diagnosis amongst male and females would diminish in terms of diagnosis of lung cancer. And this is a Globocon 2018 data, which is very, very fairly reliable. And this is what we are also seeing more and more in our clinical practice. Can you go to the next slide? Garima, next slide. You can see that the estimated number of deaths in lung cancer are pretty high, and this is an age-dependent phenomena. This is a dependent phenomena which is increasing over a period of time. By 2040, the World Health Organization predicts that in India you would have close to 1,11,804 patients being diagnosed with lung cancer, and we can see that in our practice also today. Now, when we talk about the mutations, we know that lung cancer is a mutation-driven cancer or immune, responsive cancer. ALK positive mutation is generally seen in adenocarcinomas in lung cancer. This was a paper published by Amanjeet Pal and Navneet Singh et al., which showed that in India, in northern India specifically, the incidence of ALK positive mutation was as high as up to 8%. Different papers have shown this incidence to be between 1.6 to 11.7%, but in our practice, we close to see as close to 6 to 7% of the patients will end up having lung cancer. ALK rearrangements in lung cancer can be of multiple types at multiple domains, but they tend to have a similar morphology of patients. These are typically adenocarcinoma patients. They are typically never or very light smokers. They tend to occur at a younger age. there are a lot of diagnostic techniques available today. We are using NGS. Most of us are using NGS as a common platform, and they are mutually exclusive. Rarely we find patients with biclonality and both mutations, but majority of these patients have a single mutation. Now, discovery of ALK fusion was done in 2007, and since then there has been a lot of newer therapies which have been directed successfully against the management of this cancer. A small number of patients have an inversion at chromosome 2, which leads to fusion of ALK gene with EML4 gene, resulting in ALK EML fusion protein. This is the pathology that leads to driving force as far as this lung cancer is concerned. When we look at the timelines in terms of ALK positive tumors, the ALK fusion was detected in 2007. The first drug was approved as crizotinib in 2012. But since then, there has been a plethora of drugs, from alectinib, ceritinib, brigatinib, to alectinib being approved as the first line, to lorlatinib, being approved as a first line in 2021. At present, what are the unmet needs? ALK positive young patients are generally younger. They have a larger survival advantage from starting a drug at an earlier stage. They are non or light smokers. CNS metastasis is quite high in ALK positive tumors. It can occur in up to 20 to 40% and associated with poor prognosis. There are a lot of resistance which these tumors generally develop on the first line of therapy, and they become resistant to the subsequent usage of the same TKI. And untreated patients, there are resultant clones. When we treat that with second or third generation TKIs, the incidence of clonal population having resistant clones goes down. Lorlatinib is a third generation ALK TKI. It's selective, ATP competitive, highly potent drug. It has an excellent brain penetration, 75% to address brain metastasis. It has a potential to improve clinical outcomes with overall survival and intracranial activity. In addition, upfront could completely suppress or delay the onset of target mutations. When you compare lorlatinib with a crizotinib, the molecular structure of crizotinib is open as compared to lorlatinib, giving it a smaller molecular size and a higher brain penetration, and it binds more highly effectively to the ALK resistant mutations, typically the G1202R and G129A. Let's look at the CROWN trial. This was one of the landmark trials which was reported in NEGM in 2020, where ALK positive patients were compared between two subgroups of treatment of lorlatinib and crizotinib. This trial randomized patients with stage 3B, stage 4 ALK positive mNSCLC in the first line setting with or without CNS metastasis and more than one extracranial lesion into lorlatinib versus crizotinib group. The groups were further stratified in basis of ethnicity and the presence of brain metastasis with with a target to measure the both progression-free survival, overall response rates, both by independent reviewer. So the study enrolled close to 300 patients, and they were randomized between May to February 2019. All patients underwent a restaging CT chest and brain imaging every 8 weeks. 103 patients were in the lorlatinib group, 147 were in the crizotinib group, 149 in the lorlatinib group, 103 patients in the lorlatinib group, and 31 patients in crizotinib group remained on the study treatment. Median duration of follow-up for PFS was 18.3 months and 14.8 months respectively. The baseline characteristics, both the groups were fairly well matched, and majority of them were never smokers, but some previous smokers were also there. Very infrequent number of patients were current smokers. If you look at the brain metastasis, very high number of patients had brain metastasis, 26 patients in lorlatinib group and 27 patients in crizotinib group. Some of these patients had received prior radiotherapy to the brain. So it was very interesting to see the primary endpoint in terms of progression-free survival. The progression-free survival almost doubled at 12 months, and the curves were so far apart that it was very obvious that which was the best drug. The hazard ratio of 0.28 was very impressive. The median PFS was not reached in the lorlatinib group. It was 9.3 months in the crizotinib group, as seen in the previous studies with crizotinib previously. When you look at the progression-free survival by independent investigator, you can see that the drug did fairly well. Up to 80% of the patients were doing well at 12 months, and which was very, very comforting, versus 35% of the patients in the crizotinib group. When we looked at the subgroup analysis, non-Asian patients did fairly well than the Asian patients. The patients with brain metastasis did fairly well with lorlatinib as compared to crizotinib. Never smokers did much better with lorlatinib as compared to crizotinib. The overall response rates were fairly decent. You can see patients with partial response 73%, patients with some form of a response close to 80 to 90%, and median time to response was only 1.8 months, which was seen similar in both the subgroups. But what was interesting is that the intracranial response was much higher in the lorlatinib subgroup as compared to the crizotinib, and this was, this was one of the most important milestones that we want to achieve in our patients, especially with brain metastasis. So you can see the intracranial time to progression by independent reviewer. The lorlatinib did much better as compared to crizotinib, and this is primarily because of the indigenous nature of the drug to cross the blood-brain barrier. Majority of the patients with lorlatinib did remain brain metastasis free. In terms of overall survival, it was not reached in both the subgroups with the hazard ratio of 0.72. This also favored a lorlatinib-based modality. The study period was less, and the final results of this overall survival will be interesting to see whether this leads to a definite improvement in overall survival in future. In terms of safety profile, the safety profile was almost similar in for both lorlatinib and crizotinib, as fatal and adverse serious events, but of the similar proportion. In terms of permanent discontinuation of treatment, again, similar proportion of the patients had to continue or discontinue the drug. The most common side effects of observed with lorlatinib were hypercholesterolemia and hypertriglyceridemia and edema. And few of my patients who are on this drug, this is one of the most common problems that they are facing today. Rest, it's a well-tolerated drug. It leads to some mood disturbances, some vision disturbances, but in other terms, in terms of causing liver dysfunction, in terms of constipation, in terms of nausea, it's a much better drug as compared to crizotinib. If you look at the quality of life survey, lorlatinib was superior to crizotinib in terms of quality of life. Majority of the patients felt on lorlatinib felt better as compared to crizotinib in terms of quality of life. So in conclusion, and this is my one of the last few slides, lorlatinib resulted in significant longer PFS, higher intracranial responses as compared to crizotinib. The intracranial response rate was 82% in lorlatinib, with 71% had a complete response rate. The safety profile of lorlatinib was fairly good. Grade 3, grade 4 were more frequent with lorlatinib as compared with crizotinib, but however, the majority were laboratory abnormalities, and they did not result in discontinuation of the drug. These results support the use of lorlatinib as the first line. NCCN also recommends as a category 1 recommendation to start lorlatinib as the first line in comparison to ceritinib or crizotinib. How do we manage hyperlipidemia? Pitavastatin, pravastatin, or rosuvastatin should initially be considered based on the low involvement of CYP450 enzyme. I screen all my patients for triglyceridemia at the start of diagnosis, and subsequently make patients regularly aware about monitoring the cholesterol and triglycerides level. We do it at baseline, 1 month and 2 months, and periodically thereafter. And hyperlipidemia generally resolves with lipid-lowering drugs. Also encourage these patients to use exercise and lower lipid intake. The CNS effects, generally it leads to mood alteration and cognitive and speech disturbances. They were more common in patients with brain metastasis, up to 71%, and 24 patients required more than 1 dose modification because of the drug CNS side effects. If you look at the drug side effects in terms of lorlatinib-related CNS, When we have mild or a grade 1, we continue the same dose or with elder dose until the recovery to the baseline, re-challenge by reduced dose by 25 milligram. Grade 2 or moderate to severe, we withhold the drug until it becomes grade 1 and then reduce it by 25 mg. When they have a life-threatening drug, any intervention is indicated, permanently discontinue Lorlatinib. This is for the company's recommendation. So with this, I would like to thank the organizers again and sort of end my talk. The podium is back to Garima and Dr. Nandini to take it forward. Thank you very much.